Good day, friends. Now we begin a new lecture about surgery. Lecture of ulcer disease. So our lecture peptic ulcer. Peptic ulcer is well known and old disease. We know about disease more than 2000 years, but now it's main in actual, of course. Why? Peptic ulcer usually occurs at the age of 25-40 years, so young population. Maybe most early population disease like juvenile age ulcers, infancy. After 45-55 years, ulcer disease rare and not classic. It's most common for men's than women's, and single ulcers more than multiple ulcers. No, maybe something like classic double localization of ulcers, so name mirror ulcers of duodenum, for example. Its main problem of gastroenterology too. Its main problem from the 19th century. And despite our success in surgery and gastroenterology, there are many things about prevalence, continuous chronicity, life-threatening complications require intensive study of these pathological processes. It may be dangerous from the complication side. It may be dangerous from the death side. Minimal aspect of the stomach anatomy. So it consists three layers: mucous, submucous, and muscle. And serous, of course, is overcoating. They are thick layers, and mucous has many folds, especially of the large cavature. Muscle layer very thick and very strong because peristalsis of stomach very good. It needs for good nutrition. If we say about parts of the stomach, we can say there is cardiac part, this part from the esophagus to the stomach junction. There is fundus of the stomach, this side. There is body of the stomach. There is angle of the stomach or small curvature. There is antral part of the stomach and pylorus. After stomach become duodenum bulbous and distended part and part. Blood supply. Blood supply of the stomach very good. There are many arteries that blood supply the stomach. The main vessel blood supply stomach is truncus celiacus. Truncus celiacus, there is special branch arteria gastrica sinistra. And from truncus celiacus and hepaticus artery, there is arteria gastrica dextra. They are small curvature arteries. And there is a branch from the pancreatica duodenalis artery, arteria gastrica epiploica dextra, and arteria gastrica epiploica sinistra from the big curvature side. And there is fifth source of blood supply of the stomach. They are arteria gastrica brevis. They are between spleen and big curvature of the stomach. This picture from the back side of the stomach, we can see the back side of the stomach and truncus celiacus and pancreas and spleen and colon transverse. No, this is movable organ because it has mesored stomach, ligaments. And if we want to mobilize and reset stomach, we can make. Lymphatic system of the stomach big and not simple. The first collector is near small cavity and truncus celiacus. Second, near spleen and arteria linearis. Third, gastric bracket dextra and pancreas. And fourth, liver. And if we say about oncology of the stomach, we can think about these lymph nodes and cut off during radical operation, like stomach resection, like gastrectomy. Innervation. The main organ innervate stomach is vagus nerve. Vagus nerve goes longitudinally the esophagus. There are two vagus nerves, anterior and posterior, so left and right. The name of the vagus nerve between cardia and pylorus part is Laterge nerve. Laterge nerve. There are many branches of the Laterge nerve near cardia, and there are branch of the Laterge nerve near pylorus. There is a special name of these places: goose paw. This is big goose paw. This is small goose paw. Vagus innervates the stomach. It's entrophic nerve. During stimulation of the vagus, we can see hyper salivation of stomach and water in H4 and pepsin, and it's contracting the muscles of the stomach, of the fundus and body, and it open the pylorus during stimulation. It's open pylorus during stimulation. So it's mixed nerve, entrophic and contractive nerve. It's very main for understanding function of the stomach, to understanding the nutrition by stomach. It's main for us to say about vagotomy as one of operation of the ulcer disease of the stomach. Right and left vagus nerves. We say about them like parasympathetic innervation of the stomach. Of course, there are plexuses in the stomach wall, and our stomach has automatic contractive function despite the innervation of the vagus or sympathetic nerves. So automatic we have. Peptic ulcer. There are many theories to understand why. Appear chronic ulcer of the stomach or duodenum. Ulcer, so not healing wound. No, one from first theory is Virkov. Say about sclerotic process, not enough blood supply. So sclerosing or thrombosis or embolism of arteries of the stomach. After this become ischemia, local ischemia, and appear chronic ulcer. But we say that blood supply of stomach very good, and very rare we can find signs of the local ischemia. So this is theory not working in the real world. Peptic theory. I think peptic theory most leading, most famous in the world. We say about hypersalivation and alteration by juice mucose. So, and hydrochloric acid and pepsin. If we have more of these substances in our stomach, and they can nutrite the mucose. So after this may appear the ulcer, chronic ulcer. Peptic. It not explain why appear hypersalivation, but it's, I think, true theory. Mechanical. Shov trying to explain the ulcerogenesis by gastrostasis, duodenostasis. So elongation of the time standing of the of the content of the food, of the acid into patency of the stomach or duodenum. Elongation of tongue become to the appearance of the chronic ulcer. No, if you say about this theory, you need confirm it. So make special investigation to prove. Yes, we have gastrostasis or duodenal or we have not. Cellier. It's not so old theory, stress theory. Yeah? Considers peptic ulcer to be adaptation syndrome result. It includes such a point that any of stimulus, stress, neuro, psychic, physical, infections one, increased secretion. So again, peptic theory. Due to adrenal and pituitary hormones stimulating and increase of gastric secretion a long time leads to the chronic ulcer formation. And the last theory, of course, it's infectious theory. So Helicobacter pylori is a famous bacteria in our ulcerogenesis. 38% of gastric and more than half of duodenal ulcers, they are connecting with the Helicobacter pylori. It's acidophile bacteria. How acid properties in our stomach so better for bacteria, just opposite for other bacteria. How to find this bacteria? We have EGDS biopsy. So during biopsy, we take piece of the mucosa under microscope. We can see these bacteria and we count them. Then breath test. There is special enzyme of bacteria. We can find the urea formation after this and find it during breath test. And of course, we can find antibodies to H. pylori during blood analysis. So, Helicobacter pylori, now most famous theory of the ulcerogenesis. According to this, we can treat. And by the way, we have successful treatment according to classification. Classification according to the localization, of course. So, gastric ulcer could be cardial, maybe corporeal, maybe entral, maybe pylorus. And duodenal ulcer maybe bulb and most lower retrobulbar ulcers. In classification, of course, we can every time say about complications. And there are 5 very famous complications of ulcers. They are perforation, bleeding, penetration, stenosis, and malignization. And we say if we have uncomplicated ulcer, this is one view, one tactic of the treatment, most gastroenterological. If we say about complicated ulcer, the tactic is just opposite, and maybe we can say about surgery. Very famous classification of the ulcer is Johnson classification. According to this, we have 4 types of the ulcers, 3 types of the gastric, and 4th is duodenal. So, type 1, true mediagastral ulcers in the body of the stomach, usual in small curvature. Johnson explained ulcerogenesis of this type by reflux of the bile from the duodenum to the stomach. Type 2, associated gastric ulcer and duodenal ulcer. So, 2 ulcers. 1 ulcer in the stomach, its usual entral part. Second, in duodenum. And type 3, prepyloric ulcer. So, in the pyloric area and over it, little over. Type 2 and type 3, they are most peptic about etiology. At type 1, I told you about duodenogastral reflux of the bile. No, type 4 is duodenal ulcer. I repeat, Johnson's classification is famous in whole gastroenterological world. Symptomatology is so clinical, the ulcers. It's easy disease. We can put diagnosis only after conversation by the patient. There are many specific symptoms of the ulcer disease. We can say about localization. We can say about complications of ulcer only after conversation. So, classic main symptoms of the ulcer: the pain, heartburn, irritation, nausea, and vomiting. The pain. What the pain is classic for the ulcer disease? It's fasting pain, then pain after meal, then night pain, and seasonal pain. Fasting. If our patient not feeding long time, appear pain in the epigastric or right epigastric region. Then our patient meals and pain disappear. Second, pain appear after several time after food. For the duodenum, half hour, 1 hour and more. For the stomach, 10 minutes, 15 minutes. No, in these numbers. So, if our pain appear after meal, this is classic peptic ulcer pain 2. Night pain. So our patient cannot sleep or awake during due to pain and go to the milk or the water drink or the milk drink or the take food, and after this pain diminish. This is night pain. And seasonal pain, that we know that exacerbation of the ulcer is mostly in at the autumn and the spring seasons. They are 4 classic ulcer pains. Second, heartburn. Of course, because we have hypersalivation. Irritation, maybe, of course. Vomiting. The vomiting may be 2 types. One type, when on the height of the pains, during very big pain syndrome, our patient goes to the toilet and makes self-vomiting and pain disrelief. A second pain may be during stenosis. In this case, our patient can make vomiting by yesterday food. But the vomiting of the ulcer disease is classic symptom 2. Diagnostic. Now, of course, main diagnostic method is fibrogastroduodenoscopy. It's not only it's diagnostic and very good diagnostic method. From the 2 sides, we can see the ulcer, we can see the mucosa, we can see complications. Second side, we can make biopsy and have pathological confirmation of our ulcer and may suspect cancer and other advantages. So, the main diagnostic method of the ulcer disease is fibrogastroduodenoscopy. Second investigation is X-ray, Röntgen contrasting investigation of the stomach by barium. We can see direct and indirect signs of the ulcer. Direct signs, it's niche Howdeck signs, inflammatory infiltration, convergence of the folds. Indirect, I show later. Next investigation, gastric secretion test or pH metry. We can measure the property of the gastric juice. We can say it increase, decrease, or it's normal. I repeat, the main diagnostic method is fibrogastroduodenoscopy. So, example, we can see the ulcer. we can see the ulcer. We can see the deep ulcer with fibrin on the deep. We can see ulcer with hyperemia round, and we can see mucose. X-ray. We can see the esophagus, stomach, duodenum. We can see niche. This is symptom of the big ulcer. This X-ray, like this X-ray, we can see niche and conditions of the falls. This and this and this conditions of the falls. So this example of the X-ray. That's all about investigation. So investigation of ulcer is easy. Fibrogastoscopy if we need X-ray rentgenography. Treatment. Now we can say about classic treatment of the ulcer. We say about uncomplicated ulcer. We usually say about uncomplicated duodenal ulcer. Because duodenal ulcer not afraid from the oncology side, malignization, and we say they are true ulcers, and we treat them according to our schemes. So, classic therapy is tree therapy. It consists of three drugs. First is PPI, proton pump inhibitors. You know many of these: omeprazole, rabeprazole, pantoprazole, lansoprazole, esomeprazole, and many others. This about omeprazole, 20 milligrams twice a day, or lansoprazole, 30 milligrams twice a day. And we give two antibiotics to eradicate the Helicobacter pylori. First is clarithromycin, half gram per day twice, and penicillin, 1 gram per day twice. The time. First drug we give more than 3 weeks. Usual time is 6 weeks if it's effective treatment. Antibiotic therapy only during 1 week, not more. If a chief effect, so our ulcer healing, we say our patient is healthy and we finish our treatment effectively. If ulcer not healing, or we have H. pylori test positive after treatment, in this case we can think and say about quadrotherapy. It's not so easy like tree therapy, have many drugs, but maybe denol, bismuth containing drug, or tetracycline antibiotic, or metronidazole, or very strong PPI drugs like lansoprazole, esomeprazole, dexilant, or H2 blockers, ranitidine, famotidine in these doses. So we make quadrotherapy and we treat according to this scheme. If it's effective, we finish our treatment. If it's not effective, we can think about surgery. Indications to surgery may be indirect and direct. Indirect. So, not cicatrizate, not healing during 6 months after effective, complex, rational and therapy. And we can, in this case, we can think about plain surgery, because in this case can appear complications. We want to prevent them. Direct, all complications of ulcer, there are direct complications to the surgery. Surgical treatment. What about surgical indications too? Formation of a callus ulcer penetration of ulcer, ineffectiveness of conservative treatment, and recurrent ulcerous bleedings. They are indications to surgery. They are direct indications. Stomach resection was main operation of the surgery. What is stomach resection? We cut off the part of the stomach. The classic stomach resection of the ulcer is when we cut off 2 or 3 of part of the stomach. Of course, we go from the pylorus and over. If we cut off the pylorus and angle and minimum half of body of the pylorus, the name of this operation stomach resection. There are many modifications of this stomach resection according to how many we cut off the stomach. Is not main, and how we anastomize our stomach after stomach resection. If we put anastomosis between stump of stomach and duodenum, our stomach resection names Billard 1. If we anastomize the stomach with the jejunum, stump of stomach and jejunum, then the famous name of this operation is Billard 2 resection. I can explain it later. So, Billard 1. This is place we cut off. This is anastomosis between stump of stomach and duodenum. So, name of this operation, stomach resection, Billard 1. There are many variants of modification of this operation, like Lidiger, Billard, Kocher, Gaberer, Finsterer. They are about how big stomach resection, what the place of the anastomosis, what the length of the anastomosis, which wall of stomach we choose for the anastomosis, and other. But the general name, Billard 1. Second, Billard 2. Billard 2 modifications, there are many modifications of Billard 2 resection, and most famous was Goffmeister-Finsterer, this one. Again, we cut off this part of stomach, and then we stitch the stump of duodenum, this one. And after this appear 2 loops, efferent. And efferent, this new thing after surgery, we make it. And then we make gastro-jejunum anastomosis. And I show you Goffmeister-Finsterer. This is scheme of Goffmeister-Finsterer. So, stump of stomach, gastro-jejunum anastomosis. This is efferent loop is short, the length not more than 7-8 centimeters. This is anastomosis retrocolica. This anastomosis retrocolica. So, our anastomosis behind the colon transversum, an efferent loop and stump of the duodenum. So, this is scheme of most famous stomach resection Billard 2. The name of this modification, Goffmeister-Finsterer. Vagotomy. No, most easy of course stem vagotomy. During this operation, we resect 2 nerves, trunks of the nerves, vagus nerves, left and right. If we go to this operation and make it, we say that after my operation become hyposalivation and become little paresis of the stomach wall contraction and become pylorospasmus. It's worse of these things. Hyposalivation is good for us. Hypoperistalsis of the stomach not so big and dangerous. Pylospasm is very bad. So if we go to the stem vagotomy, we want to combine this operation with other operation, with the stomach drainage operations. There are few operations you need to know them. Most famous operation. First is gynectomy Coolidge. So we made longitudinal incision of the pylorus, this one, and then stitch in a cross direction. By this operation, we cut off the pylorus and we prevent pylorospasms. So this is gynectomy Coolidge pyloroplasty. Second operation, like this. This is Jaboulet. In this case, we make this is direction of the stomach and pylorus of duodenum and stitch in this direction. So we make new big hole between stomach and duodenum. Like Jaboulet is Finney pyloroplasty. This one. And the last type of stomach drainage operation is gastrojejunostomy. We don't touch the pylorus. We put additional anastomosis between stomach and jejunum. In this case, function of the pylorus disappear because we have additional hole to drainage. So I make combine stem vagotomy with gastroenterostomy too. So for operations to drainage stomach, gynectomy Coolidge and Jaboulet and Finney and gastroenterostomy. Maybe most famous is gynectomy Coolidge because it. So stem vagotomy. There is very big advantage of stem vagotomy. It's very easy and mini-traumatic. They are disadvantaged because it's not functional. It goes to disturbances of the stomach, it goes to the disturbances of the liver and pancreas. So, second operation name, selective gastric vagotomy. In this case, direction of the incision, little lower of stomach of the stem vagotomy. We present the branch to the liver, to the pancreas, to the pelvis minor. In this case, we minimize extra gastric complications. From the gastric view side, it's same like stem vagotomy. The last operation, vagotomy, it's selective proximal vagotomy. We say this is best type of the vagotomy operation. I can show you the direction of the incision, this one. In this case, we don't touch the lateral nerve, the trunks of the vagus nerve. We only dissect branch from these trunks to the small curvature, to the stomach, fundus and body. We mobilize and cut off these branches. And we present, of course, small goose paw. So innervation of the antral part and pylorus. The name, if you make only this operation, isolated proximal selective gastric vagotomy. In this case, we have after operation hyposalivation of the stomach juice. We have hypocontraction of the stomach body. And we have save the innervation of the pylorus and we have not pylorospasmus. If we say about uncomplicatedly duodenum ulcer, if we say about best operation of this situation, we can say the isolated proximal selective gastric vagotomy is the best operation if we compare these types of vagotomy. No, as any other operation, it has indications and contraindications. Vagotomy. I told you about range operations and I repeat them. Complications. So it was plain surgery. Now we can say about two main complications when appear complications. They are perforation, they are bleeding from the stomach or duodenum. First, perforated ulcer. No, you should know this Mondor triad. First is sudden severe abdominal pain, like knife pain. Second is boat-like abdomen during palpation of the confined teeth, and during percutation of the abdominal wall, you find the disappear of the liver dullness. If you see patient with this clinic, you should administrate it only to the one investigation. The investigation is only one, plain X-ray. If you not if you confirm your diagnosis, you should investigate only to one investigation. I repeat, plain X-ray. You not make EGDS. You not know about diagnostic laparoscopy. We can say later. So only one investigation if you suspect perforation, plain X-ray, because you can find stripe or falciform booming on the right side of the diaphragm. This is pneumoperitoneum symptom. It's pneumoperitoneum symptom because from the whole of the stomach or duodenum to the peritoneum cavity goes air. It go upstairs and you can see on the diaphragm. Why we look to only right side? Because from the left side this traube space, and you can miss right diagnosis. So we can see only right side. How to, if we have perforation of ulcer, our actions, our operation would be very speedily. So we can make something during 2-6 hours, not more, because after this perforation become peritonitis. One example of operation of perforating ulcer is open polycarpov operation. When we not stitch or resect the ulcer, we tamponate it by omentum. We tamponate it by omentum and stitch this omentum around our ulcer. It's like tampon, glue the hole and prevent moving of the stomach content and treat our situation. Of course, there are many other operations to treat perforation, like JAT Horsley excision, because edge of our ulcer, it's chronic, may be very infiltrative, and our sutures could be insufficient. We refresh edge of these ulcers in this direction, rhomboid direction. We cut off the edge of the ulcers. And according like DNA culture, we stitch in a cross direction. This is Judd Horsley excision of the ulcer. It not narrow the outcome from the stomach, and we cut off the duodenum during this operation. Then maybe you can say, if it perforation, we can say about stomach resection. We can say about stomach ulcer stitching and vagotomy. There are many types how to operate perforative ulcer. But if you know minimum two types modifications, one is open polycarpal and second is just, maybe enough for your answer. So our operatives could be maximum in 6 hours because we can miss peritonitis. If you see perforation, you just now go to the operation. And you're afraid from the complication. This also main complication is peritonitis. How you delay diagnostic of the perforated ulcer, so worse for the patient, of course. Second and the last complication I say you, it's ulcer bleeding. Ulcer bleeding is hide bleeding. We cannot see the source outside. It has local symptoms and general symptoms. The local symptom is hematemesis and melena. You know that during ulcer bleeding, the blood color is not red one. It's brown color. And we say that it's like coffee ground mess. And we say the name of the substance H-chlorhematine, name of the substance, hematine. This results of neutralization by blood by H-chlor. So coffee ground. How vomiting by coffee ground appear you that there is bleeding. Second is melena. So it's dark one, it's liquid, it's multiple, it's smell. How big melena and frequent, so worse for patient, so bigger bleeding. And general symptoms. If we have profuse bleeding, so we can name this as hemorrhagic or hypovolemic shock. If it a long time waiting and little bleeding, we can say about post-hemorrhagic anemia as result of it. There is very good scale how to measure type and severity of bleeding. This is endoscopic scale of the bleedings classification. The name Forest. What is Forest 1? Forest 1 is acute bleeding during investigation. You can see bleeding from the artery Forest 1A, from the vein Forest 1B, or parenchymatose. And if you see continuous bleeding, of course you can say this is indication to emergent surgery. Just now I can go to operation because I afraid from the shock and death. Second, Forest 2. So the second name of Forest 2 is unstable hemostasis. We can see non-bleeding visible, yet non-bleeding visible vessel. We can see adherent cord. We can see hematine on the ulcer base. In this case, Forest 2, the very big risk of recidive of the bleeding. And somebody says this is indication surgery too. So Forest 2 is not so easy like we think. It's maybe recidive bleeding during 1 hour, 6 hours, many days. So you want to watch these patients or treat or maybe just now operate. And Forest 3, very good for us, no bleeding. Because on the ulcer base there is or fibrin or white clot. If we see fibrin and white clot, we can see no bleeding now and no bleeding recidivate. So Forest 1 forest 2 and forest 3. According to these bleedings, you plan your tactic. Maybe forest 1 is emergent operation. Maybe forest 2 urgent operation, so during several times, 1-2 days. And forest 3 no operation emergent. We can say about plain gastroenterology, plain surgery, and other things. Forest classification. Example. We don't want to operate this bleeding if we have something to replace it. This is example how to arrest bleeding by endoscopic hemostasis. You can see the ulcer with the clot here. And after the thermocoagulation, we can see white stroop, white fibrin on the ulcer floor. There are many other types how to arrest the bleeding of the stomach or duodenum ulcer without classic surgery. And the thermocoagulation and laser exposure and special staples and other devices. Of course, they are expensive, they are effective, and they reduce trauma due to our action. So we cannot say that it's more, that operation, of course, most dangerous, most traumatic. We prefer this is modern types of arrest of bleeding. If they not enough, if we have received the bleeding, or if we have these things in our equipment, we can go to the plastic surgery. So stitching of the ulcer, stomach resection, vagotomy, excision of the ulcer, and many other types of operation. One example how to make arrest of bleeding if we have backside duodenal ulcer with the bleeding. So first laparotomy, then I go to the longitudinal pylorododenotomy. Then I find on the back wall of the duodenum the bleeding ulcer and stitch them. So first step, I stitch the bleeding ulcer. Second step, I stitch pylorus in a cross direction pyloroplasty. And third step, I make bilateral stem vagotomy. In this case, I stitch the bleeding source. I reduce hypersalivation by vagotomy. I cut off the pylorus. I have not pylorospasmus in after operation. So this is example of the organ saving operation due to bleeding duodenum ulcer. That's all. Thank you for attention.